chat and we'll do questions at the end.
Okay, let me just right. Good morning, everyone. I'm just going to share my slides, and whilst I do that, I'll just introduce myself. Sorry, I'm just getting the slides up actually. So my name's Professor Anna Murphy. I'm a consultant pharmacist at Glenford Hospital. I've been working in respiratory medicine for many, many years now, over 20 years. Still got a real sort of passion for respiratory. I'm hoping that you'll be able to see my slides there. Lucinda, can you just confirm the slides are on and they're moving forwards? Is that right? Yes, wonderful. Thank you. Okay, so so I've been working in respiratory for, like I said, over 20 years. My passion is really asthma, COPD, interstitial lung disease. I do 3 clinics a week, work in the severe asthma service, which is a tertiary referral here up at in Leicester, and I also professor of pharmacy practice at De Montfort University as well. And it's absolutely wonderful that I've been invited to speak to you today regarding the management of asthma in primary care. And what I've tried to do is consider the fact that we've actually got new guidance for asthma being launched this Thursday at the British Thoracic Society winter meeting. So I can't present you exactly what those guidelines are because I've only seen the draft and the draft following the consultation, but I think we know exactly what the guidelines are going to show, and I'm going to give you a bit of an insight in today regarding those guidelines. Okay. I've also been in contact with your head of medicines optimization for the ICB, Giles Owen, and he has very kindly shared a draft guidance of the new Northampton and NEAN prescribing guidelines for asthma. So I will be sharing those with you today, but they are only draft, okay? But it helps to bring into context what I'm talking about, the national guidance, and how it reflects then for you in primary care. So let's crack off and let's get started, okay? So a few declarations of interest, just so you are aware of those. I just really wanted to start with, probably a bit of a geeky pharmacist really, but I'm quite interested in when medicines were launched and where we started, how we started treating people and things like that. And really, I think one of the important things to realize about asthma is it is very much an ancient disease. So the scriptures from China and Egypt around 2600 BCE that mention symptoms of sort of breathlessness and respiratory disease. But it wasn't really until Hippocrates, who was the first person on record to link asthma symptoms to the environment and trade such as metalwork. So he started really to think about asthma being triggered by environmental factors. And at the time, that was quite unique, but something that we obviously still need to consider, need to ask our patients as much as as part of our structured review. Then there was this doctor named Henry Salter, and this was in the 19th century, and he started to accurately describe medical drawings of what happens in the lungs during asthma attacks. He talked about intervals of respiration, heavy respiration between attacks. So again, now we're starting to see the variable nature of asthma, which again is something that we still see today, that asthma is a variable airways disease. And then in 1892, William Osler started to talk about bronchial spasms. He noted similarities between asthma and allergies. So again, building on what perhaps Socrates was thinking about in the all those many years ago, and also then starting to see that it runs in families and starts in childhood. Again, things that we question as part of our asthma review. Is there a family history? When did your symptoms start? Do you have variable airways disease? What triggers your asthma? So these have all built us to have the sort of consultation in with our patients today. But thinking about triggers again, such as climate, extreme emotion, and diet. And I guess, over the years, we have very much, when it comes to treating asthma, changed in our approach as well. So in the 1970s, and bearing in mind that Ventolin, salbutamol, was launched in 1969, asthma was really just a disease where the airways were bronchoconstricted. So if we gave a short-acting beta-2 agonist that bronchodilated the airways within 3 to 5 minutes, we actually treated asthma. Okay, I will show you some data in a moment that shows that actually that approach was not the correct approach. And indeed, today we shouldn't just be treating asthma with short-acting beta-2 agonists. In fact, I'm going to give you an argument to say we shouldn't be using short-acting beta-2 agonists at all. Okay, and that's what the new guidelines are. Later on in the 1980s, we start to think much more about asthma as an inflammatory disease. So the eosinophil started to become an important element of the management of asthma, thinking of it as an eosinophilic airways disease. And now we think of bronchospasm, we think of inflammation, and we also think of remodeling. And this is where if you don't control the inflammation within the airways, you get the sort of collagen being pushed underneath the epithelium, and you lose that bronchospasm. So patients end up with fixed airways disease. And now with some of the new treatments we have, we are almost starting to talk about sort of remission of asthma. Okay, but I'm not going to go into that in great detail today. So you can see since the 1970s to today, the sort of pathophysiology of asthma has changed, and therefore the approach to treatment needs to change or must change. And this is some of the data that I alluded to. So this is when short-acting beta-2 agonists were first launched, and these are very sort of potent beta-2 agonists working within the airways, isoprenaline and phenobarbital. And this is when isoprenaline and phenobarbital were launched in New Zealand. And you can see this is the asthma mortality per 100,000. And here you can see just underneath the phenobarbital arrow here, in the 1980s, a huge spike in mortality, and it was linked to using phenobarbital as a short-acting beta-2 agonist. So that's equivalent to salbutamol, but salbutamol is not as potent as isoprenaline and phenobarbital. But we do know that overuse of short-acting beta-2 agonists in asthma is associated with an increased risk of mortality. And there's a number of studies that support this all the way through. So I don't need to tell you about the National Review of Asthma Deaths in 2014. I'm hoping that all of you are aware of this very important document. So it's 10 years old now. But it showed that out of all those people that died of asthma during that 12-month period where the patients were analysed, we showed that the underuse of inhaled corticosteroids was related to deaths, and that overuse of short-acting beta-2 agonists was linked as well. And in fact, 39% of patients in NRAD were prescribed 12 or more salbutamol inhalers in a 12-month period. In fact, I think 4% were prescribed more than 50% of short-acting beta-2 agonists. So we know that was very much linked to asthma deaths. More recently is an AstraZeneca-supported study where they used SABA use in asthma. It's the Sabrina program. And what they did, they actually looked at SABA use across 5 to 6 countries in Europe, and then also looked at the risk of death. And this is a Kaplan-Meier plot of overall survival. And as you can see here, that if actually you're using in more than 11, which is the blue line of the salbutamol, your increased risk or your chance of dying early is much higher than if you're only using 0 to 2 salbutamol inhalers in a 12-month period. So again, supporting this fact that salbutamol in asthma is linked to asthma mortality. There's another few things I want you to consider also with salbutamol as a drug. It's not a very effective short-acting beta-2 agonist. It's called a partial agonist. So you can fill about 30,000 of your beta-2 receptors within your airways, but you're probably only going to get 40% clinical efficacy. So you can increase the dose but you actually don't. You reach a ceiling point, which is the top of the dose response curve, that you could carry on giving salbutamol, but you're not going to get any more bronchodilation. And that's really, really important to realize. You can also develop beta 2 receptor tolerance. It can lead to, in fact, more bronchial hyperresponsiveness within the airways. There's in vitro data saying that it can increase eosinophils. And of course, from monitoring point of view, we know that high doses can lead to hyperkalemia, tachycardia, our patients increase in anxiety. It becomes a habit. It's their security blanket. I get that, but it's not actually doing them any good for their asthma. Good for emergency treatment, obviously, but this is not what we're necessarily talking about here, and can also cause like the tremor and patients' hands lock and go into spasm. So these are some of the side effects. And when you look at the Sabrina data, the UK is pretty poor compared to the rest of the countries. So overuse, which is 3 or more SABAs in a year, 9% in Italy compared to 38% in the UK. So we are very reliant on salbutamol within the UK. And like many of you know, working with respiratory patients, adherence to inhaled corticosteroids is often very poor. And people use the inhaler that, well, that works for me. That blue inhaler, it helps my breathlessness. It may help the symptoms, but it's not actually treating the asthma. Okay, and that's the problem. We have got a situation that patients aren't really treating their asthma, only treating their symptoms. So we have a few challenges. We know that even people with quite mild asthma can have severe or even fatal exacerbations, and that was true of NRAD, that it wasn't just the severe patients on lots of medicines that were dying, it was across the spectrum. We know that SABA monotherapy has a greater risk of exacerbation and mortality than those patients treated with inhaled corticosteroids. And often those patients end up in hospital or having OCS courses. We know that over-reliance of SABA, even if they're on inhaled corticosteroids, can worsen the inflammatory response, causing more bronchial hyperresponsiveness and increase effects of the triggers. And we also know that the recurrent exposure of airways to SABA also contribute to decreased response to SABA as a reliever, perhaps when it's actually needed in that emergency situation when they're coming into hospital. And what we need to do is try and dispel this love that clinicians and patients have about the blue inhaler, because that's what people think is the treatment for asthma. So this is where we are now, and this is what we need to now look at. And we need to remember that asthma is an inflammatory disease. It's where the immune system is overactive. So we need to really reduce and reset the patient's airways and their epithelium back to normal, okay? And that's what salbutamol isn't doing. And we need to remember that the eosinophils, and I'm not going to go through this in any detail, but I just love these pictures of this. This is a parasite worm, and these are the eosinophils attacking the worm. And of course, that's what eosinophils are in our body for. They are to actually treat worm infections. Some of our patients with very high levels of eosinophils, we will need to screen for strongylosis just in case they do have worms. But for the majority of patients, it's just where the immune system is producing more eosinophils. It's gone wrong, basically. We don't necessarily know why, but at a trigger that's causing the bone marrow to produce more eosinophils, they are going into the bloodstream. They take probably about 8 days to actually mature, and then they migrate into the blood vessels and travel to target organs, the lung being a prime suspect and a prime area for these eosinophils to go to. They've got nothing to do in the lungs, they release chemicals, and it causes the whole cascade of asthma. And this is really where we are. And apologies, this is quite a complex picture, but this is really how complex now asthma is. So, going back to what Socrates was saying all those many years ago, is this is where we are now. These are all the different cytokines and endokines that are involved in the pathways of asthma. And some patients will have more sort of allergy driven asthma, others will have more sort of non-allergic asthma, but majority of patients will all end up with eosinophils within their airways. So it is time that we start to manage asthma in the 21st century, and these are the new draft guidelines. So the draft guidelines from NICE, which are replacing the British Thoracic Society and SIGN guidelines. So we've actually managed to all parties to work together. So they've collaborated. The remit was really to mainly to look at the diagnosis and the treatment management. So the initial clinical assessment and diagnosis, ongoing risk stratification and pharmacological management, and the rest will be refreshed in time. It came out for consultation in June, and it's being published on the 27th of November. One moment. Sorry about that. That's when you work clinically, and but there's a patient just turned up, so apologies for that. So this Thursday, how exciting is that? That gave you a moment just to take in that exciting news whilst I spoke to the nurse. So let me tell you what's in the draft. So this is what this is what the diagnosis is, and I'm a pharmacist, but diagnosis is essential, because if we're giving patients medications, we want to make sure we are giving the right medication to the patient at the right time. So thinking about the diagnosis, and actually this is really interesting for you working in primary care, because they've tried to simplify the diagnostic pathway. Now, I know there's a lot of reports and questions raised as part of the consultation. So please don't take this as being the definite algorithm for diagnosis. Okay, it might change, but this is what they've proposed. So 90% of diagnosis of asthma is doing a very well constructed, structured history of the patient. So again, based on, you know, family history, symptoms, presentation, trying to think of differential diagnoses. Okay, but you need to support that with a diagnostic test. So what they're suggesting is blood eosinophils, so looking to see if there's been any raised blood eosinophils over the last sort of 3 years, or if you've got access to exhaled nitric oxide, and that would be raised above 50 ppb. If you haven't got those, or those are normal, then you could do bronchodilator reversibility. And again, if that is normal, then you could move on to bronchial challenge testing. Okay, so that's methacholine or mannitol testing. Okay, and these are your results here. So if the eosinophil count is above the range, yes, you can just diagnose with asthma with the good clinical history. If no, then you move up. This is what you'll be familiar with the reversibility, and then bronchial hyperresponsiveness, and then you can consider the diagnosis. So that's the diagnostic draft. Okay, there's also a diagnostic draft for 5 to 16-year-olds, which you'll be pleased to see as well. Again, this is not so much reliant on blood eosinophil counts, but is using pheno testing. Now there is I know probably many of you don't have access to exhaled nitric oxide machines, but I'm not quite sure in Northampton if you're sort of developing sort of diagnostic hubs that might be included in there, or you know, there has been a push as part of the accelerated NHS England scheme to try and get pheno more into practices. It's a very, very useful, very easy test for clinicians to do. So shall we think about the pharmacological management? So there's going to be 3 different algorithms: asthma under 5s, asthma 5 to 11, and asthma 12 years and over. And I'm really just going to concentrate, I'm afraid, in interest of time, to look at the asthma 12 years and over. But for those really keen, the guidelines will be published on Thursday, so you'll be able to have access to those, the 5, 11, and under 5s. So this is a bit of a change. So if you think of the normal guidelines, the addition of using a salbutamol inhaler on its own has actually not been in the guidelines for a number of years, but it still is the practice. Now, I've noticed in the comments that, you know, a few of you are saying, well, we haven't got the diagnostic, we haven't got access to spirometry or to pheno. And that's probably been the challenge. So you felt that, you know, you didn't really want to give people medication. So you'd give them a salbutamol because that would probably be just, help with their symptoms. But it didn't mean that patients felt that that was the right treatment for their asthma, perhaps came over reliant on it. And that's really where the habits of being on a salbutamol started. Now, this is still important that you get a diagnosis, and you have to make that decision if you can wait for that diagnosis or not. But once you've got the diagnosis, instead of actually giving salbutamol or using a regular BD ICS plus a salbutamol PRN, the recommendation, if it's mild asthma, that you offer low dose inhaled corticosteroid and formoterol. So the formoterol aspect, so I've got a really bad cold, is a long-acting beta-2 agonist, but it works very quickly. So we're in 3 to 5 minutes. So it works very similar to salbutamol. So the patient will feel like they're getting bronchodilation, and therefore it's helping the symptoms, but at the same time they're getting a shot or a hit of inhaled corticosteroids. And remember, what's happening is those airways are inflamed, probably due to eosinophils. So the eosinophils only have to sniff a little bit of inhaled corticosteroid and they will shrink away. And over time, that ICS will build up a barrier around the lung to help the eosinophils to actually recruit it into the airways. So it stops that whole process. Okay. So using ICS formoterol ticks the patient box, but also ticks the box for treating the asthma. And the recommendation is to use it as needed. So patients won't need a short-acting beta-2 agonist like salbutamol at all. Okay, they would just be given an ICS LABA. And as this is over 12, we should be offering a dry powder inhaler as first line. This is where most of the evidence around this type of approach, in fact, the only evidence with this type of approach is with Symbicort Turbohaler. But new guidance in Leicestershire and in Northamptonshire are saying this is a class effect. So you could use your Fobumix Easyhaler, and in fact, that's what we're recommending. So this isn't sort of MART. This is more we call this AIR, anti-inflammatory reliever medication. Okay, and it is only for patients with mild disease. And there's very good evidence. There's a couple of studies, Sigma 1 and Sigma 2 study. I'm not going to go into it in huge detail, but just to reassure you that there is good 12-month evidence. This is ad-needed salbutamol, and this is ad-needed budesonide and formoterol. And as you can see, the risk of exacerbation is reduced by 64%. Not surprising, because you are giving treatment for asthma. Remember, as needed SABA only treats the symptoms. But you can also see that if you look at this graph on the right, that if you compare budesonide formoterol versus just budesonide with SABA, which is our current sort of starting treatment for asthma, you can see that actually the probability of having a severe asthma exacerbation is the same, but this is using budesonide and formoterol as an anti-inflammatory reliever, so just when they actually need it. So it's actually over this 12-month period, 52 weeks, is similar to using regular BD budesonide plus salbutamol PRN. So very reassuring data. Okay, and you can do that actually by reducing the amount of steroids that is required as well. So you get a 83% reduction in steroid use. So you're actually giving patients less steroid overall than if you would using MART in these very mild patients. And there's lots of data. There's over a total of like 547 publications that are looking at this as needed ICS formoterol and mild asthma. And this is a task force for anyone who's really interested in the evidence behind it that you might want to look at. And I'm just going to actually scoot over these a couple of slides, but this is in mild asthma, ICS formoterol versus as needed SABA. So this is where people are just using SABA on their own, which a lot of our patients do because they stop using the ICS. And you can see that this approach is favoured in all these clinical outcomes here. Okay. What we do see, though, in patients who are on sort of low dose maintenance ICS, there are a few things that maybe the bronchodilator FEV1 and post was slightly less, but it wasn't significant, and maybe FeNO was slightly higher overall, but this was over a 12-month period. So there are a few outstanding questions that some of us may have, but generally the task force for the ERS and NICE has recommended that this approach should be adopted across Europe, and the UK, as part of the British guidelines, which are published on Thursday, have also adopted this approach. So there are a few limitations to consider. Cost effectiveness is something that I'm sure the ICB will be looking at. We need probably longer term studies. There's limited studies to this approach in children, and we don't know if they're effective with different ICS formoterol combinations. But I said, all of these all of this probably is a class effect as long as it's formoterol, which is the LABA that's included. Okay, the Sigma study was all dry powder. So the Sigma was an AstraZeneca study. I'm just answering a question in the chat, and that was with the Turbohaler device. But we do think that the Easyhaler, Nexthaler, whichever devices, I know you use a lot of Easyhaler like we do in Leicestershire and Northamptonshire, is actually as good with then probably the terbutaline. So, but that's only for people with very mild asthma. Okay, if they have more regular symptoms, and I'll go through the standard of what I would expect patients, or when you start with MART, you would use MART. So hopefully most of you are quite familiar with MART. So this is using an ICS formoterol combination, but it's maintenance morning and evening. So 1 dose or 2 doses morning, 1 or 2 doses evening, and then they can use the same inhaler for PRN use, up to 8 or 12 inhalations of the ICS LABA, depending on the preparation that you're using. And that's quite familiar. You're probably used to using MART, but this is now really for a majority of our patients where you would start. Okay, so you would start with MART. We're not going to be using, Clenil or QVAR, BD plus SABA, that traditional sort of approach to asthma is being being removed really from the guidelines. Okay, so if the person who's needing asthma presents who are highly symptomatic, e.g. regular nocturnal awakening or with a severe exacerbation, you start treatment with low dose MART. Okay, so you don't forget about the air. The air is really for those patients who have very mild symptoms, maybe only twice a month. Okay, so majority of your patients that I think you'll see in primary care will be starting on MART. Okay, you can always go back down to air if as needed, if symptoms are very few and far between at a much later date, or patients I think will probably do that themselves without being told. But generally most people will start on MART therapy. So start MART or air, and this is again the guidance here. Symptoms most days, waking 1 night a week. If they're currently smokers, impaired perception of bronchoconstriction, so that's where patients don't realise that they're having asthma exacerbations, recent severe exacerbation, history of life-threatening asthma, so any ITU admission for asthma, keep them on MART, and any sort of seasonal trigger exposure. And this is MART, and the reason why MART works, and I think you've probably seen this graph by Anne Tattersfield, who is a professor in Nottingham. This is basically what happens with an asthma exacerbation, where up here at the top of the peak is where patients end up receiving oral corticosteroids. But 5 days before, or 5 to 10 days, there's this window of opportunities where you see nighttime symptoms going up, you see morning peak flow dropping, you see SABA use going up, you also see FeNO increasing, you see blood eosinophil count and sputum eosinophilia going up. So you see that there is this opportunity here to increase the treatment which is required. And because the eosinophils are increasing, we need more steroid. So actually using the ICS LABA PRN increases the amount of ICS that patient is receiving, and therefore knocks out those eosinophils. So you may get a blip, but you don't get a full-blown attack. Okay, and that's the maintenance and reliever. And there's excellent data, so supporting MART therapy. We just probably haven't adopted it as well as we should have done. It has been licensed for many years now, but it hasn't really been adopted as well as we should have been in practice, because the evidence around MART is very, very compelling. And it isn't just anti-inflammatory. You do get formoterol, which also helps to reduce the risk of severe exacerbations compared to SABA. So there is a sort of synergy really between the ICS and the LABA together. And we know it's much more effective than using ICS LABA plus SABA in both eosinophilic and non-eosinophilic patients. So it really is a very sensible approach that the NICE guidance have taken. And it's not just about, treating that underlying inflammation and reducing exacerbations. I've also shown you graphs that show you have less ICS exposure to the patient. You manage that asthma inflammatory variability. So when patients' asthma symptoms vary, their inflammation varies, and therefore we need to vary their treatment. So it actually follows what treatment is needed. By doing that, we can improve overall asthma control. We can reduce SABA prescribing and the associated costs and risks of overusing of SABA. We can reduce the carbon footprint because we're using one inhaler, and therefore for some patients that may be cheaper if they've got, paying for prescription charges. It is simple for patients, just carry one inhaler around with you. And like I said, there's one prescription charge. There's a lot of resources to support you. So if you are aware of the Primary Care Respiratory Society, excellent resources on there. The nice thing about the PCRS is these resources are free even if you're not a member. I would urge you to become a member if you're interested in respiratory, because there's a lot of extra support you get from being a member, but these sort of resources are available. So please take copies of, or Google the PCRS and get copies of these resources to help you. And then if you've got a patient who you've got sort of put up to moderate dose MART, so going from 1 to 2 doses twice a day plus PRN, and they're still not controlled, there is still the option of adding in Montelukast. Montelukast works in probably only about 40% of people with asthma. It tends to work with those people who are more allergic. We need to be aware of the fact that it can cause sleep disturbances. So watch out for nightmares with your patients, and if it's very troublesome, problematic, then to stop it. And I tend to give I think the guidance says a 3-month trial. You generally know if it's going to work after a month, if I'm honest with you. But 3 months is probably quite sensible to give a 3-month trial and stop it if it doesn't work. Long-acting muscarinic antagonists, so tiotropium Respimat, or if you use Trimbo for asthma in Northamptonshire that has a LAMA in it, then they have a very limited place, I think, in people with asthma, more for people who have breathlessness or have been ex-smokers or also have overlapping COPD. So we don't promote a lot of tiotropium use in our patients, but if we do, again, we give a 3-month trial, and only in those patients who have got evidence of sort of more fixed airways disease, or who have got obstructive airways where we want to sort of help with their breathlessness. So that's the sort of the treatment that we would add in at that stage. These are your draft guidelines that Giles has very kindly shared with me, and this helps to put it into context for you. So this is what I've been talking about at the top. So asthma symptoms less than twice a month. So this is your mild, these are your sort of air asthma inflammatory reliever patients. So you're using the ICS LABA as needed. The first line choice, and it's recommended to use a dry powder, not because of the environment, but because actually most people can use the dry powder inhalers and they don't need to carry a spacer around with them, which many of our patients won't be able to or don't tend to carry spacers. And really MDIs should be used with a spacer device. So the FOBI mix, this is for children over 12 and adults, 164.5 easy haler, 1 dose PRN. Okay. Majority of patients for start, if they have asthma symptoms more than twice a month or more, and then you do the MART. So you start with low dose MART, 1 dose BD plus 1 dose PRM. And then you do have an option of an MDI there as well, so Bibecfo or Lufabec. And then if that doesn't control patients, they're still having symptoms, then we can increase the 2 doses twice a day, 1 plus 1 PRN, and then you've got the MDI option there as well. So very, very flat, very simple management of people with asthma. The severe asthma or the high dose ICS, really we should be referring through to secondary care for the higher doses. Using Nexthaler for those high doses because it is actually more cost effective, and patients only need to have 1 inhaler a month. But the FOBI mix, if patients like that device, is still available there. Because we've gone to high doses, and that's more of a needed really when we're considering people going on to biologics, we do have to give the patient a salbutamol as a backup rather than using high dose in a marked way, because this is unlicensed and could be unsafe in some of our patients. Just to let you know where this all fits in with your current patients, because you might want to swap some of your patients over from the traditional regime to the flexible. This just gives you an idea of how we were treating our patients and what the equivalent in the colours above are for our patients. Okay, do look at this bottom box here, because that tells you how many doses can be used by each of the different ICS LABA over a 12-month period. So look at the licensing. So I talked about referral through to secondary care, and that's important. Very few of our patients, probably 5 to 10% of the asthma population, will need to be have higher doses of inhaled corticosteroids, and then we need to consider referral through to secondary care. So it is very few numbers. Now, I don't know what Northamptonshire's like, but if I look at some of our prescribing data on our asthma registers in certain areas of Leicestershire, we've got very high prescribing levels of high dose inhaled corticosteroids. And it's worth remembering that high dose inhaled corticosteroids only really work for a very small proportion of patients. And as I said, it's more for patients that are being lined up for, injections or further treatment for their asthma. The dose response curve for inhaled corticos is very, very flat. If I just go back to the guidelines a moment and just to explain, if you take 1 dose of formoterol, 164.5, and use it twice a day, we're going to the box here, that actually causes about 90% clinical efficacy. So it's actually working really 90% of the time for those patients. Okay, and the high dose here is about 100%, the top of the dose response curve. So here, these are really for those patients where we will start to see a systemic circulation. You will start to see patients having adrenal suppression, osteoporosis, diabetes, which is why we want to restrict this use to patients who only really require it. But there is little benefit going up to the higher doses, okay? Apart from the fact you're going to give them systemic circulation, but we will do for more severe disease. But try and think of, in primary care, most patients being treated within the left of this black line. Okay. So consensus pathway for managing patients. So this was an AHSN ACC, so it's the Accelerated Access Collaboration that developed this consensus pathway for managing uncontrolled asthma in adults. So indicators of uncontrolled asthma, so over previous 12 months, 2 or more courses of OCS, okay, 1 or more hospital admissions or ED attendance, the 6 SABA, or could indeed be 6 ICS LABA, we need to still monitor overuse of ICS LABA if they're using it PRN, poor symptom controls, or maintenance OCS for asthma. So that's your indicators of uncontrolled disease. And then it's set out what should be the responsibility of primary, secondary, and severe asthma centres. So moving from so patients with uncontrolled asthma, so if they do have uncontrolled disease, they are suggesting that patients with 2 or more courses of OCS are referred to secondary care. And I note the note in the comment box about referral through in Kettering is over 12 months in my experience. This is obviously a concern, but there are things that you can do in primary care before you refer. So if you identify these patients, do confirm that the diagnosis is correct. There is probably good evidence that probably about a third of people that are on asthma registers do not have asthma, and that may be why they're exacerbating. We're not treating them appropriately. We do need to make sure that we have got the right diagnosis. We need to make sure that we have reviewed and optimized inhaler technique and think about, can they use their inhaler? Are they actually using the inhaler? So think about adherence. Look back, how many inhalers have they actually inhaled corticosteroid containing inhalers have they collected over a 12-month period? In my experience, and this is most of the patients that get referred through to our tertiary care centre, we studied this, we published on it. 80% of patients were 65% of patients were collecting less than 80% of their inhaled corticosteroid. And we need the inhaled corticosteroid usage to be up at 75, 80% and above, okay, for them to benefit from the treatment and to reduce exacerbations. So if they're not adherent or not collecting their inhaled steroids, then that's that whole discussion around what's motivating them not to, what are their concerns, what are their beliefs about asthma, how can we get them to adhere to their treatment, which I know is challenging, but a lot of if we can try and address that in primary care and get people to have better inhaler technique and better adherence, you'll have less people that need OCS doses and less referral into secondary care. Obviously, look at the guidelines and make sure we are treating them effectively. Give them a trial of Montelukast or a trial of a long-acting muscarinic antagonist just to see if that helps. Think about other differential diagnoses, so anxiety, depression, smoking, mental health disease, all these type of things that can actually affect people's asthma. Allergic rhinitis, so make sure that we treat the nose well. I'm always ask all my patients about if they've got any nasal congestion, can they breathe through their nose. Make sure that if we're giving nasal sprays that we've taught them how to use nasal sprays. So nasal spray technique is as essential as inhaler technique. Most people do it wrong. You do not sniff when you use a nasal spray, okay? Right hand, left nostril, lean forward, spray with the nozzle pointing outwards towards the top of your ear. You spray and you don't sniff, and then you use left hand, right nostril and do exactly the same. But nasal spray technique and adherence is also really important in people with allergic rhinitis because it actually helps to treat their asthma. And then refer, and then there's guidance for secondary care in terms of what they should be doing, and then it leads on to the patients from Kettering and Northampton being referred up to us here at Glenfield, where we have the option of biologics for asthma now. And this is why that referral pathway has been developed, because we do know there are patients still on maintenance doses of OCS in the community. We know that people are having frequent courses of OCS. Now, if they're adherent and fully optimized and no differential diagnosis, we need those people now onto biologic treatment for their long-term health. We have tezepelumab, which is an anti-TSLP, benralizumab, mepo-rezi, which are all 3 anti-IL-5, which targets the recruitment and release of eosinophils from the bone marrow. We have dupilumab that works on this pathway here, IL-4, interleukin-13, and Xolair here that targets the IgE. Okay. Unfortunately, no, patients can't access any of these medications without going to a tertiary referral centre. Once they've been assessed at this and it's been discussed and approved by a severe asthma MDT, then patients will be commenced on treatment, and then patients are being repatriated back to Northampton General, and we are working on the repatriation of patients back to Kettering once services are in place and able to support this. So we have a number of your patients who are being treated with these injections, all subcutaneously, either given 2 weekly or up to 8 weekly, depending on the drug. There are nice guidance, which is why they're not easily accessed, because there's still a huge amount of cost. Some of these cost £1,000 a month, and you can see the sort of, we're looking for patients who have a blood eosinophil count of 300 or 400, 3 or 4 exacerbations in a 12-month period, and dupilumab and has a little bit about pheno, and tezepelumab is pretty much 3 or more OCS courses or maintenance OCS with no other biomarkers. We can think about putting people onto these medications. So in summary, despite efforts really to improve asthma management over the last 30 years and the availability of really effective medicines, I mean, inhaled corticosteroids have been widely used since the end of the 70s, 80s. LABAs came out in the 80s. We really haven't managed to reduce the mortality associated with asthma, and a lot of that is that patients have over-relied on the SABA. So we've taken, or the guidance really is taking a more population approach to managing asthma, and saying actually we need to remove for day-to-day use the use of SABA, and to ensure that patients use the ICS. They have the formoterol as a combined inhaler if they need the reliever aspect of their care. ICS are the cornerstone because they treat the disease. They treat the eosinophilic airways disease. And even when we put people onto these really fancy biologics, they still need to maintain on the ICS because it has a very wide mechanism of action that really helps to dampen down that whole asthma pathway whilst we target the aspects that we think are driving that individual patient's disease. So the new NICE guidance and global international asthma guidelines, which came out first, recommend this flexible approach to managing asthma to address this and to improve care. So we have AIR on its own, and then we have MART, and with the so MART is anti-inflammatory reliever, but on top of maintenance dosing. AIR, anti-inflammatory reliever, is literally just on its own for very mild patients. Most of our patients, as I said, will be on MART therapy. If they do continue to exacerbate when you've gone through, you've checked adherence, inhaler technique, then we should be assessing and referring patients to secondary tertiary care for consideration of biologics. And that's all I'd wish to say. I've got about 10 minutes, I think, left to answer any questions. I've tried to do some as we've gone along, Lucinda, but I'm happy to take any further questions.
Yeah, so I'm just seeing, I know you answered the one about the Sigma study. But another one saying about patients that have side effects to LABA, is that right? Anxiety shakes. What do you suggest?
Okay, that's a great question. So I would, in my experience, a lot of the time, the side effects related to SABA or LABAs is actually related to technique. Okay, so think about what is the patient's technique? If they are using an MDI, are they breathing in too fast? Are they actually in reality using a spacer device? They might tell you that they are, but are they using it just for the twice a day? Do they actually carry it around with them? I think I ask many of my patients, and a lot of them will say, yeah, I use it for morning and night, but I'm not carrying it around with me. It's too big, it's too bulky. It doesn't, people just carry their phones more, especially men. So is that the reason? Because we all know that most of our patients that use MDIs, because it's a propellant, it's coming out at 60 miles an hour, the patient, it's so easy to breathe in too fast and then for the drug to impact on the back of the throat, and therefore they swallow it. You get systemic side effects. You've got beta 2 receptors in your skeletal muscles, so that's why it causes a shake and it causes hands to lock and go into spasm and cramp. So it's a systemic side effect really of the short and the long acting beta 2 agonists. So think about technique. Even with spacers, people can still breathe in too fast. So if you've got the aero chamber, easy chamber, I'm not sure what you use a lot of A2s actually. We don't use the A2 in Leicestershire, but I don't think that whistles when you breathe in too fast. So just make sure that I might be wrong, stand me corrected if I am, but make sure they breathe in very slowly and steadily. So, MDIs are gentle. It's an internal sigh. It's very
Mhm.
slow and steady. If they have got a DPI, then make sure that they are breathing out first before using the device, making sure they have their chin up. And this is the same with an MDI. So think about positioning of how they're using their inhaler, and then breathe in really quickly and deeply.
Mhm.
Okay,
Perfect.
so make sure that is the way that they're using. So if they're getting tremor, shakes, cramps with an MDI, try a DPI. If they're getting with DPI, confirm technique. You might want to change them back to an MDI. They were better on that, so it's about individualizing the care for your patient. Think
Mhm.
about what dose they're on. Can you actually, can we somehow, you know, are they still using SABA? Can we cut out the SABA altogether? Can we increase their ICS? There's no evidence from this, but sometimes if you're using Foster, Lufebec, it's very fine particle. You may get some more absorption through the lung. I seem to see that more people sometimes get those side effects. So try them on Fobimix or one of the other alternatives.
Perfect. And then question about a mother whose daughter has seasonal asthma and just uses a blue inhaler. Which inhaler is recommended for this?
So how old were they? Were they over? I did see that question. Were they over 12?
Bernadette, you can 10.
10.
10.
Okay. Well, I for Fobimix is now licensed from 6 up. So at the moment, I would wait till Thursday. So the guidelines for the under 12s are coming out, but basically 5 and upwards, they are starting to sort of really push more using the ICS LABA, so the air approach, even in that age group, because it gets people into that mindset of actually treating asthma. Whereas if we sort of continue with the ICS-BD and then the SABA PRN, they're going to reach 12 and then we convert them over because we've got more evidence. So it will
Mm.
depend on your local guidelines, but the NICE guidelines being published are sort of sort of recommending or suggesting that we do that. So it is licensed in that group BD, but you could use the air approach for that with that child. That may reduce
Yeah.
the overall long-term burden of ICS. So might need it regularly during the seasonal time, and to remember to start using it. But if they had it, at least when they started getting symptoms, they'd get the ICS, which is what you need to dampen down the asthma. Whereas at the
Yeah.
moment, all she's got is a SABA.
Yeah. Okay. Perfect. And then question of can patients easily access, I can't pronounce that,
Yeah,
omalizumab?
omalizumab. Yeah, so no is the answer. Sorry, Rachel.
Okay.
Yeah. Omalizumab is also used for CSU, so urticaria, which may be more accessible locally. That's a locally commissioned indication, but for severe asthma, it's specialist commissioning still, so it's still going up to Leicester for the centre.
Perfect. And then Rachel just wants to clarify. So we need to be using Fobimix more than Symbicort, and both have a license for MART and air regimes.
Not totally correct, Rachel. I will take your first point and say yes. I think we'd like you to be using more Fobimix. It's a very good device. It's got dose counter on it, which is very clear for patients. It's very easy for patients to use. They obviously still need instructions, and if you're prescribing it and haven't got time to do it, remember to refer through to your community pharmacist for a new medicine service so they can check that for you. Symbicort, so both are licensed for MART. Symbicort is the only one that is licensed for air, but as I said during the talk, Leicestershire, Northamptonshire, most areas around the country are saying it is a class effect and using the most cost-effective and devices. But both the Turbohaler, so Symbicort Turbohaler and Fobumix Easyhaler are both two very, very good devices.
Okay, good. Lovely. And then if they're patients who rarely get symptoms and only use their blue inhaler a few times a year, do we need to still put them on a preventer?
Yeah, great question, Gemma. This is a sort of a dilemma there, isn't it? Just confirm why are they using their salbutamol, I guess. We have dished out a number of salbutamol over time when people have had viral infections, and we have really not ever got any diagnostic biomarkers or even a structured good history of them really ever having asthma. So for those patients, I wouldn't just say, all right, we're going to put you onto the ICS LABA, because you've got to think about the risks there of introducing an ICS that a patient may then start overusing, particularly if it doesn't work that well for them. So I guess there is that little bit of a step back to say, why is this patient on a blue inhaler? What pieces of the puzzle have we got to actually say that this is asthma? Structured history, blood eosinophils, feeder if you're lucky enough, variable airflow with peak flow or spirometry ideally, but like one of the comments earlier, you don't have access to spirometry. Our spirometry weight for general spirometry in Leicestershire is absolutely shocking. It's about 80 weeks, 80. So we are in a right muddle here. So if you're doing better than that, well done. But this is so Gemma, that's what I'd say. I'd just take that step back with that type of patient and really find out if they actually even need an inhaler at all.
Rachel's just come back to clarify. So where would we stand putting somebody on Fobumix for an air regime, or can we not do this?
Yeah, you can stand very tall and be very well protected, because it is put into the NICE guidance that it's a class effect. So you've got national guidance, and you will have the local guidelines that Giles Owen and his team are producing with the respiratory specialists at the hospital to ensure that you are covered. Okay, so you will be covered. And if you go to court, I'll stand up beside you. Won't come to
and
that.
then if a patient is very controlled, low dose ICS, should we switch to an ICS LABA if not using a SABA?
So that's again is a conversation you might want to have with your patient, Kerry, because they're well controlled. You could argue that you don't need to rock the boat. They're on low dose, so I'm quite happy with that. So we're not causing harm from the ICS. So you could put them onto ICS LABA and use it in the air approach if you wanted to. I'm quite tempted to say I might leave them, if I'm honest with you, and sort of concentrate my time on the patients that are uncontrolled, or we can get better control of their asthma. So I would check what we mean by control. So I do the ACT, I check their lung function, I just, make sure that they really haven't got symptoms. But yeah, there's still a few questions I have about air, but I'm perhaps a little bit of a skeptic. Everyone else, we have 12-month data. If this patient is happily using their inhalers low dose, I might keep them on it and not using their SABA.
Perfect. Any other questions? I think we've covered them all now. Let's have a little look. Yeah, that is all of them. So anybody else before she goes?
Yeah,
She's
happy
very
to
pick
happy
her
to take
brain.
any. No, not at all. I just, I mean, what do you all does it feel good, the right thing to be doing for patients? Is it going to make your life more difficult? I don't know if anyone's got any comments.
No, I mean, I I don't manage asthma at all, that I've arranged this because obviously this is what they've asked for. So I can imagine those decisions are, as the prescriber, are difficult to know whether that decision is the right decision.
Yeah, yeah. I think Vicky's made a really good point there. I think the hardest thing, I think starting patients will be much easier. You've got a very flat treatment. It's actually easier, almost like one inhaler, isn't it? That's all you need to learn. Perhaps have in a toolkit, you've got an MDI and a DPI, and that's it maybe. But I think if you're thinking of switching patients off SABA, there's a couple of things you want to think about. One, if they are very high SABA users, are we just going to switch their SABA to an ICS LABA and do more harm in some ways because they overuse their ICS LABA? Okay, so you need to be a little bit careful. You need to monitor those patients to make sure that they're not overusing. The second thing, patients love their salbutamol inhaler. Are they going to trust this approach? That's some of those discussions which I think is going to be more challenging, and perhaps that's something we could do a follow-up and think about those difficult consultations, I think, with patients around this, I think would be really good. Yeah, like Rachel, you've said here, absolutely. Patients have become so reliant, it's their security blanket, that's SABA. That's why they order so much. They don't want to go anywhere without it. We've drilled that into them over the years as well, and now we're changing what we're saying, and that's difficult, but not impossible. And I think we will do well. Yeah, absolutely. We need to review it, Mandy. Oh, that's a good point. Use your SNOMED codes. So there's a SNOMED code for MART, and I'm trying to put pressure to get this SNOMED code for air developed. There isn't one at the moment, but as soon as the guidelines, they've promised me, as soon as the guidelines are released, there will be a SNOMED code. I think they're automatic on ARDENS, but if you use them, then you've got a way to audit and pull off those patients in your practice. Hope that's
Brilliant.
helpful.
Yeah, it's been really brilliant. So I might have to have you back again in about 6 months' time.
Hopefully I won't have a
Because
cold because I feel a bit full of it today, Lucinda. So hopefully that didn't come across too badly. So
no, it's been absolutely brilliant this morning. Your session's been amazing. Maybe you could get a rep or somebody. Yeah, I have a rep. I have somebody that can go through it. So that's fine. As in, do you mean in terms of the different types of inhaler, Emily? As in the ones. I'll wait for her to reply. Really helpful, thank you. Da, da, da. So my plan is to send out a feedback form just so I get to know what people want, because your session, Anna, was based on the request for an asthma update. So it's been
okay.
awesome to have you. So I'm really grateful.
No, thank you for the
Um,
invitation. It's been a
and
pleasure.
then I'll most probably be in contact maybe in 6 months and do another one in 6 months if that's okay. Fab, great. Emily says just go through for the GPs as well as us. Yeah, okay. I will take that feedback to the team. Thank you so much. Yeah, and maybe PLT as well. Yeah. So I'll send out my feedback form because these sessions were based on your feedback from the last one in July. Anything you put down, I will try and get people to come and update you. So I'm also really grateful for all of you being here because the last session had 15 people and this has had 50 today. So it just goes to show that if we get the word out there, we can get everybody updated. We'll try and run it again as well. So thank you so much to you all. And then if you've registered and joined, it will come through that you've joined and I can then send you an email out. Okay. And then Anna's just shared her email in the chat if anybody has any questions. Yeah, and it's going to be recorded as well. So you'll be able to have access as soon as I've kind of clipped down the sessions into manageable chunks. Okay. Thank you so much. I'll stay on until everybody's left, but I'm really grateful that you've all joined today. realised I could just answer, Claire. Yeah. So I'll send the feedback form out, and as soon as you've filled it out, sent it back, then it just shows me that you've attended, and I can then send out the certificate. All right.
Perfect. Thank you.
Thank you, and thank you all so much for coming. I'm really grateful.